Okay. So indications for airway clearance. Retained secretions is one of the reasons why you would want to clear secretions from somebody's lungs. One of the things that, some of the things that can cause retained secretions are atelectasis. Okay. When a patient has atelectasis. Intubation. Anytime somebody is intubated, they will not have effective and productive cough, okay, because their airway will be partially open because the ET tube goes through it. Cough is nothing but explosion of air to a closed airway. So because the glottis is partially opened up when the ET tube goes through it, they don't have effective cough. That's why we always have to suction the mouth. Ineffective cough mechanism. You need your respiratory muscles to cough. Okay, you gotta have strong muscles. For instance, if you have something called the MIP and the NIF. Those two tests there are used to measure the strength of the respiratory muscles. And if you have normal MIP and normal NIF, and vital capacity is another one, it means that you have strong respiratory muscles and you can clear your airways of secretions if you need to. Okay. If you're in pain, you don't want to cough effectively to clear your airways of secretions. Now think about somebody who just came back from major surgery. Okay. It's very difficult for them to cough. Anytime they try to cough, they feel the pain, but if you must get your patient to cough to some extent, there's something called sprints. We'll give it like a pillow, hold it down, so that would tend to decrease the amount of pain that they feel when they want to cough. Paralysis, when you paralyze somebody, there are times when we have to paralyze patients on the ventilator. A patient that is fighting the ventilator like crazy, we can paralyze them so that they can move. Okay. So once you paralyze them, you are also paralyzing their diaphragm and their external intercostal muscle. So they can't have effective cough, and as a result of that, they have retained secretions. Neuromuscular disease, that will also affect your respiratory muscles. Okay, Guillain-Barré, myasthenia gravis, muscular dystrophy. And then we have cilia dyskinesia. So if you look at the trachea, the cilia are those lower hairy looking structure on the wall of the trachea. So what they do is to beat. They beat flag like that to move secretions to the upper airway. So dyskinesia means that they're not beating very well. They're not beating very well. When you give somebody a breathing treatment like albuterol has a lower capacity of causing mucociliary clearance. Okay? You stimulate the cilia to beat faster. Albuterol can do that. And that's how you promote pulmonary hygiene. Okay, so these disease conditions on that other side can also cause excessive secretions to build up in the airway. Cystic fibrosis, they make a lot of secretions, a lot of sticky, inspissated secretions. Pneumonia, you make secretions. Asthma, bronchitis, bronchiectasis. Okay. How about aspiration, like meconium aspiration? If a baby is born, okay, after 42 weeks, and there's an increased tendency for them to poop in utero, if something else puts them in distress, okay, they will poop. And then once the baby comes out, if the baby is not vigorous, meaning that they don't have a heart rate that is greater than 100 beats per minute, they're not crying with vigor, okay, and they have poor muscle tone, okay, we are going to immediately begin to suction meconium out of their trachea, okay. Foreign body aspiration, okay, and then sometimes for prophylaxis, okay, just to prevent them like a post-extubation. Contraindications for airway clearance therapy. Pulmonary hemorrhage, if they're bleeding, okay, is contraindicated for you to try to do airway clearance, especially if you're going to suction. Okay. One of the things that may cause pulmonary hemorrhage can be like you can have cancer inside the airway that will cause it to bleed, bright red blood, okay? They can have tuberculosis. Or maybe ruptured blood vessel. Excessive agitation or hypoxemia during treatment. Yeah. If somebody is going to get very, very hypoxemic, we may want to try to avoid that. I mean, one of the, for instance, if you're suctioning a patient, one of the most common complications associated with that is hypoxemia. That's why we always have to hypoxygenate before and after suctioning. Okay, but now if somebody is already very, very hypoxemic, you have to think about it twice before you try to do it. Feeding within previous 45 minutes to 1 hour. Okay? If a patient has just had something to eat, it may not be a good idea to try to clear their secretions. History of reflux. Okay, reflux disease. Yeah, reflux is like when stomach contents begin to come up through the esophagus, okay, and then somehow they enter the airway. Okay, it's acid. Okay, it's acid. So it causes your chest to pound. Okay, we want to avoid that if they have reflux disease. Neonates of less than 1,200 gram body weight or less than 32 weeks gestation. We don't want to do that. History of intraventricular hemorrhage, they're bleeding in their brain. Okay, we want to try to avoid that. Untreated tension pneumothorax. Because anytime you put that, like if you go to suction, if you put the catheter inside somebody's lungs, you increase the intrathoracic pressure, okay? So most of the time when you try to suction somebody, their blood pressure will drop because, the pressure in the chest will increase as a result of the catheter going down into the airway, okay? So now think about it with untreated pneumothorax, with untreated pneumothorax, the intrathoracic pressure is already through the roof. So you don't want to try to put something else inside the airway. Congestive heart failure. Okay, now congestive heart failure will make you to have low blood pressure. Okay, and then you try to suction, that's more pressure inside the chest, which will further impede venous return, therefore decreasing blood pressure. Okay? Any questions about that? So these are the techniques that we can use to clear secretions from the airway. Positive expiratory pressure, PEG therapy. Okay. A device with an expiratory resistor that enables secretions to be removed from the airway. Patient breathes in and out through the device a few times, and the device creates positive pressure. positive expiratory pressure in the lungs, propelling mucus to the upper airway and removing, promoting expectoration. So PEP therapy is nothing but PEEP. You are exhaling against the positive pressure. Okay, you breathe in and then you exhale, but you don't completely exhale to ambient pressure. You have PEEP inside your lungs. Okay? Have you ever worked with a cappella? Yeah. So at the bottom of the a cappella, that rotating at the bottom, you can tighten it up or loosen it. If you want more PEEP, you tighten it up. Okay? So that's basically what you're doing. So the pressure will displace the secretions and cause the secretions to come up to the upper airway where you can cut it out. Okay? Ventilation and oxygenation will improve after effective PEP therapy. That is true. Okay, because you're clearing your airways of secretions. You're going to ventilate better, and if you're going to ventilate better, you're going to oxygenate better. Okay? PEP has some side effects, and the side effects of PEP therapy are the same with the side effects of positive pressure. Like mechanical ventilation, decreased venous return, increased ICP, risk for barotrauma, cardiac instability, hypertension, all of that. Because PEP therapy is positive pressure, okay? Positive pressure inside the airway at the end of exhalation. And then we have forced expiratory technique, okay? Forced expiratory technique is used as an adjunct to other secretion removal device. Patient breathes in slowly and then huffs. I say huffs or hoofs, forcefully, okay? 2 to 3 times. Okay, so that is actually like trying to breathe out when your airway is open. Like that. Okay, because usually when you cough, your airway is closed. Okay, so you keep your airway open to do that. Okay? So that helps to move the secretions up. And then we have autogenic drainage. Now, autogenic drainage, you don't need any equipment. Basically, what the patient is doing is taking breaths, but progressively taking higher tidal volumes, okay, from breath to breath. So the first time they're going to take a lower tidal volume, and then they will exhale out. And then the second time they take a bigger tidal volume in, and then they exhale out. And then the third time they take even more, a bigger tidal volume, and blow out. What actually moves the secretions to the upper airway is the flow rate, the expiratory flow rate. That's why when you're done with your treatment, you always tell your patient to take a deep breath and cough. Okay, so when they take a deep breath, they're gonna have a lot of expiratory flow. Okay, when they're exhaling out to move the secretions to the upper airway. Okay, so that's what that means. From breath to breath, they're taking bigger tidal volumes. Okay, that will move their secretions to the upper airway. Any questions about that? And then we have the best, high frequency chest compression, the best. Okay, you put it around your chest, okay, and you turn it on, you kind of like vibrates and loosens the secretions on the wall of the airway. Okay, they use that a lot on patients that have cystic fibrosis. And then we have traditional chest physiotherapy, where you're going to position your patient, okay, depending on where the infiltrates are. And then you are going to focus them like that. Okay? Technically, we have 3 long lobes on the right side, the long lobes on the right side, 3, and then we have 2 on the left side. So the right lung is bigger than the left lung. And then altogether we have we have 18 segments inside the lungs. We have 10 on the right, and we have 8 on the left. Okay, so depending on where the infiltrates are, you are really faced with trying to drain secretion from about 18 lobes. Okay, it can be in different lobes. Okay, so now is it possible to remember the lobes? No, I don't remember all of them. Okay, I remember a few of them, but on the exam they ask that a lot, and you can think your way through it. Okay, because now if you want to drain anything, drain any lobe, any anterior lobe, okay, in front like this, okay, well, you're going to have to clap on them like this, okay? So the only way to get to the patient to do this on their chest, they have to be lying down, okay, on their back, which is prone. So you're going to look for an answer that says prone, okay? Well, if they say posterior something, they want you to drain the posterior segment. Well, it means you're going to want them at their back like that. So the only way you're going to get to their back is them lying down on their stomach. They lie down prone, okay? Anterior, they're going to lie down supine. Is that what I said before?
You said prone, but we know what you mean.
Yeah, I thought so. So they lie down supine if you're going to do anterior, and then if they're going to lie down prone if they're going to do superior. How about lateral? Okay, if you want to precoce on the right side, then the patient has to be down on the left side. Okay, so that's the way to think your way through it. You don't really have to remember all of them. Okay. And then we have floor valve. Now, floor valve also is like PEEP. There's usually a little ball there that vibrates, okay, the airway, to help move the secretions to the upper airway. Okay, it is positive respiratory pressure as well. Aerosolized drugs. The purpose of aerosolizing medications is to deliver it to the target organ with less side effects. So the medication is going directly inside the lungs without necessarily going all over the body. So it's not systemic. That's what the problem is, so we're going to put the medication in there. There are 4 factors that determine the effectiveness of aerosol delivery. The first one is the size and the amount of particle produced. Okay, like if you are doing nebulizer treatment, any nebulizer that can break the medication to, I think it's 5 to 10 micron. They have to be very small, but not very, very small. Okay. They can be too big. Okay. If the particles are too big, greater than 10 micron, they will run out in the upper airway. Okay. If they're very small, well, they will fall out too before they get down to the lower airway. So this is the right size of the particles. So the efficiency of any aerosol device, okay, is measured by that aerosol device producing particles that is between 5 to 10 micron. What was that?
Probably next door.
All right. Now, characteristics of the particle. Okay. Sometimes you have particles that can get bigger. Okay, they draw water in them and get bigger, swell up before they get down to the airway. Okay, so that will cause it to be heavier and may run out before they get down to the lower airway. I think they call that the particle will have like a hygroscopic property. The particle is able to draw water and get bigger before it gets down to the lower airway. Hygroscopic No, so wait a minute, that's wrong, so. Hygroscopic. You don't want particle to be hygroscopic because it will attract water and get bigger before it goes all the way down. So the next thing is anatomy of the airway. Okay. If you don't have anything obstructing the particles going down, if you don't have tumor or some kind of airway abnormality, then the particles ought to go down, okay, more effectively. But if you have something in the way of them going down, they won't rain down in the lower airway. And then the next thing is patient's perinatology pattern. The number 10, the way you should instruct your patients to breathe in is to take slow, deep breath, okay? Take slow, deep breaths. You hold them as long as you can, then you breathe out. Okay? That's basically the way we instruct our patients to do any type of respiratory therapy. You take a slow, deep breath, hold it as long as you can, and then you breathe out. Breath holding is very important in any therapy that you do. Okay, breath holding is very, even if they're doing the sinus parameter, IPPB, whatever. Okay, breath holding is very important. Okay? Now, if you tell them to take slow, deep breaths, the flow pattern is like lamina. Goes very slowly, okay? But if you tell them to do it fast, like that, we'll call that turbulent flow. Turbulent flow. And that's not good. Okay, so that's why we tell patients to take slow, deep breaths, because we want laminar flow that will put the particles down to the lower airway. These are the devices that we can use to generate aerosol. Small volume nebulizer. So that would be a nebulizer that can contain up to 1 to 5 milliliter of volume. Okay, like the one that you use at the hospital to give breathing treatment. A small volume nebulizer, handheld nebulizer. And then we have large volume nebulizer. So large volume nebulizer can contain more than 5 milliliter of volume. That's the one that we use to deliver aerosol therapy with the blue tubing. Okay, it's got like venturi at the top of it. Okay, so any nebulizer that can contain more than 5 milliliter of volume is large volume nebulizer. Okay. And then we have MDI. We can use MDI to generate the aerosol. Metered dose inhaler. Okay? The dose that comes out is already predetermined. Okay? The medication is in there, and then there is a propellant in there as well. The propellant is usually like an organic compound that they call hydrofluorocarbon. So, what the hydrofluorocarbon does is to, once you press on that canister, it pushes the medication out and then comes out with it, but then evaporates immediately, so the patient doesn't inhale it, okay? And will only inhale the medication, okay? Now, to optimize the delivery of, to optimize the benefit of MDI therapy, what do you think the patient should be doing it with? To optimize, huh? What do you do MDI with? You
Spacer?
allow the patient to, huh?
The chamber.
What do you call it?
The aero chamber.
Oh, chamber or spacer, yeah. And it's a question like that usually at the body exam to optimize the benefit of MDR therapy. The patient should do it with what? So it says spacer or aero chamber. And then when should the patient press down on the canister if they are using the aero chamber? When should they push it down? Is it during inspiration or at the end of inspiration or the beginning of exhalation or at the end of exhalation? When should they push it down? When you give it to them. As soon as they start to breathe in, they push it down. It allows them to coordinate their inspiration with pushing down on the medication. You gotta remember that, okay? And then we have DPI, dry powder inhaler, okay? Some of them will come in form of a disc, rounded, stuff like that. Right here, kind of looks like that. Okay? So what you get in there is like crystallized form of the medication. Okay? At the side of it here, there is a little lever here that before you give it to the patient, you do this motion to it, push it down. So actually what you're doing is scraping the medication down to the lower chamber. Okay, you scrape it down, and then you give it to the patient, and then you tell the patient to do active inspiration. They're doing turbulent flow. Okay? They have to do active inspiration before they can aerosolize that powder. Okay? But now with the MDI, they don't have to do active inspiration. Okay? And then another thing with DPI is that when the patient does that, don't tell them to hold their breath. You can tell them to hold their breath, but you can tell them to hold their breath with MDI because the flow is turbulent. If the patient has any condition that predisposes them to getting barotrauma, that can rupture their lungs. Because the flow is very turbulent. So that's why we don't tell them to hold their breath with DPI. Suctioning. Tracheal suctioning is indicated to remove accumulated secretions. Okay? Suctioning of the nose, the nasopharynx, the mouth, or the oropharynx is done to promote patient hygiene. You must hyperventilate and hyperoxygenate before and after suctioning. Now, most people just think that it is just hyperoxygenate. No, it's not hyperoxygenate. You have to hyperventilate and hyperoxygenate before and after suctioning. Now, hyperventilation means that you're going to give them, like if the patient is on their ventilator, you give them more breaths, more manual breaths on their own. So what that does is, CO2 is what causes us to breathe. Okay, when the level of CO2 rises, you breathe. So when we hyperventilate, you give you more breaths. Okay, we blow off a lot of CO2. We send your CO2 very low. Okay, and then we start suctioning. Okay, by the time we get through suctioning, hopefully your CO2 has not risen up to more than 45 where you will have the need to breathe, okay? And then you're fine. But now, if you don't hyperventilate the patient, that's what causes them to have a lot of, act like they're fighting you when you're suctioning them, like that. They want to breathe, okay? But if you hyperventilate them, even if the patient is not on the ventilator, actually, technically, you're supposed to use a bag, amber bag, give them few breaks, okay, so that you can decrease their CO2 before you start going in with the catheter, okay? And of course, when you bag them, your oxygen should be set, will be 100%, Okay, so they're getting 100% oxygen, and then you are hyperventilating them. Make sure that their oxygen level has come up to at least 95% or above before you start going in with the catheter. Okay? Remember that hyperoxygenate and hyperventilate and hyperoxygenate before and after suctioning. That's where it should be. Hazards of suctioning then, we have bradycardia. Now, in the baby, bradycardia is defined as a heart rate that is less than 100 beats per minute or a maintained drop of 20 points from baseline. Okay? So, if the baby's heart rate is 160, for instance, and it drops to 140, okay, and stays there, that would be bradycardia. Okay? So, less than 100 or maintained drop of 20 points from baseline. In the adult, bradycardia is defined as a heart rate that is less than 60. Okay? Well, two things can cause bradycardia when you're suctioning. Okay? You gotta be able to recognize that on the MBRC test. The first one is vagal response or vagal stimulation. Okay, and we're talking about the vagus nerve. Anytime you stimulate the vagus nerve, you cause bradycardia. Okay? You cause bradycardia. Now, the vagus nerve runs through the oropharynx or the pharynx. Okay? There's tendency for you to stimulate it when you put something all the way back in somebody's throat. You can stimulate the vagus nerve, they can have bradycardia, their heart rate will go down. And then it continues and then it runs through the carina. Okay? So if you're suctioning somebody, you go into their lungs and you go all the way to the carina, you can stimulate the vagus nerve as well. Okay? And then the patient will have bradycardia. Like when the doctor is doing bronchoscopy, for instance, the doctor has to go in with the bronchoscope, okay, all the way past the carina to suction. Okay, now the vagus nerve can be stimulated, but we pre-op the patient for that procedure. We'll give them atropine. Okay, you pre-op the patient with atropine. The atropine prevents the vagus nerve from causing bradycardia. Okay, it kind of like makes it not to be stimulated. Okay, that's what atropine does. That's why they get atropine before bronchoscopy. Okay. Now, hypoxemia. When you're hypoxemic, the initial response is tachycardia. That's the first response of hypoxemia. But as time goes on, if you haven't given them oxygen, then you will have bradycardia because the muscles will begin to get weak. Every muscle in the body needs oxygen to work well. Okay? So bradycardia can be caused by vagal stimulation and hypoxemia. So here's a good example of an MBRC question. Okay? A respiratory therapist is suctioning a patient or getting ready to suction a patient. When the therapist enters the oropharynx, they're not inside the lungs now. The therapist enters the oropharynx. The patient's heart rate drops to 50. Okay, what may have caused this? Well, most people will pick hypoxemia. No, you are inside the oropharynx. You are not even in trachea, and you are not suctioning. Okay, it's when you start suctioning inside the trachea is when you start removing oxygen from their lungs, but you're not inside their lungs yet. So what you did there is that you touched at the vagus nerve, and then their heart rate dropped. But now, if he says, well, the therapist entered the trachea, and now they're suctioning for up to 30 seconds, then the problem is hypoxemia. That's why the heart rate will go down. Now, how long do you have from the time that you enter the airway until the time that you come out when you're suctioning?
10 seconds.
10 seconds? Yeah,
That's
5
what
to
we're
10
told.
seconds. Okay. Now, supposing that you are just in there for 2 seconds, not even 5 seconds, and your heart rate goes down, are you going to stop or continue?
Yeah. Still stop.
Let's say
right?
you are in there only for 8 seconds now. We know we have a maximum of 10 seconds, but you're only in there for 7 to 8 seconds, and then they have complications. Are you going to stop or are you going to continue?
Stop.
You're going to stop, yeah. Because there's no way you're going to tell the patient, well, excuse me, I have 2 more seconds left. You don't tell them that. if you see complications, you stop right away, okay? So recognize that on the test. If they tell you that, the catheter is not inside your lungs yet, well, there's no way hypoxemia can be causing that. Okay? But if they are inside the trachea, well, it can be vagal stimulation or hypoxemia, but now they will tell you that you've been suctioning for more than 10 seconds. So you've removed a lot of oxygen. Okay? Then here's hypoxemia. That's the most common complication of endotracheal or nasotracheal suctioning. Okay? To prevent the incident of hypoxemia, we are going to hypoventilate and hypooxygenate the patient before and after suctioning. We can cause mucosal damage, okay, especially if you're going to do nasotracheal suctioning. Now, to prevent mucosal damage when you're doing nasotracheal suctioning, what would be something that we can put in to prevent that? To their nose.
Oh, the rubbery thing.
NPA.
Yeah, trumpet, right? Yeah. Nasopharyngeal airway is what you put down. It doesn't go down into the trachea, it's in the oropharynx, but it will kind of like guide you and prevent you from causing mucosal edema. You can cause atelectasis. You suction out a lot of air from their lungs, and then they will have lung collapse. You can cause infection. To minimize infection, you have to make sure that you use a septic technique. Wash your hands, put on your gloves, suction the patient. You can cause accidental extubation if you're doing endotracheal suctioning. When you get ready to suction your patient on the ventilator, take one hand and hold the ET tube, okay? Take one hand and hold the ET tube, and then you grab the ballot like that, okay? Because the patient can cough, okay? And then they can extubate themselves if the tape is not really tight. So always grab the ET tube, or they will start fighting you. The ET tube can come out in that process. Okay, so you have to know that the normal level of PaO2 in the baby is 50 to 70. 50 to 70. You can go all the way to 80, but no more than 80. No more than 80. Studies have shown that anytime a baby is given a PaO2 that is greater than 80, they end up with retinopathy of prematurity. Retinopathy of prematurity. That's where oxygen will damage your eyes, mess up some of the vessels inside the eyes, and then eventually they can get blind, really. Okay? So no more than 80, okay? Hazards of oxygen therapy. Here's that first one, the radiopathy or prematurity. That's in the baby. To prevent that, we want to make sure that the PaO2 does not exceed 80. But normal is 50 to 70. Oxygen also can cause what they call oxygen-induced hypoventilation. I think I've explained that enough. Now, oxygen-induced hypoventilation is like in the COPD. Okay? COPD patients learn to breathe based on the level of their carbon dioxide, because the carbon dioxide in their blood is already too high. Okay? They have chronic hypoventilation. So they rely on the level of their oxygen to breathe. So when their oxygen drops, they breathe. That is called breathing on hypoxic drive. That's what that means. And then if you turn around and give them too much oxygen, then they don't want to breathe, because their body is going to say, well, okay, we got enough oxygen, so we don't need to breathe. And then already they're not breathing through the CO2. Their respiratory rate will begin to go down, and then their CO2 will begin to rise. Okay? And then we call that oxygen-induced hypoventilation. Okay, get a patient like that, the first intervention is to decrease FiO2 or PEEP. You make them a little hypoxic so that they can wake up. Absorption atelectasis. Okay? When you breathe in room air, not only are you breathing in oxygen, you're also breathing in nitrogen. In fact, you're breathing in more nitrogen than you're breathing in oxygen. We have like 78.9 concentration of nitrogen in the air. We only have 21%. Okay? But the nitrogen, the volume of nitrogen that you inspire does not cross into the blood. It doesn't cross the alveolar capillary membrane into the blood. It stays inside the lungs, and that is what is responsible for keeping your lungs open. Okay, we'll call that F4C. The nitrogen establishes the F4C. So when you give somebody too much oxygen, if the FiO2 is greater than 60%, you are likely to deplete the volume of nitrogen inside the lungs. The result of that is that the lung units will not collapse. Okay? When you remove some of that volume that is keeping the functional residual capacity. And the test makes sure that you never have to increase the FiO2 by more than 10 points at a time. Like, if my patient is on 30% and they're hypoxemic, well, I can go to 35, I can go to 40, okay, but I cannot go to 45, okay? Unless that's the only choice I have, okay? But if you give me, if I'm given 35, 45, and 50, 35, 40, and 45, I'm going to pick 35 first, okay, because you have to do it gradually. If you go up very fast, that is going to deplete the nitrogen in their lungs, and they may have atelectasis. Oxygen toxicity. Okay, now usually this will happen to a patient if they have been on an oxygen level that is greater than 60 for more than 24 hours, 24 to 48 hours. Is what most books say. It's like poison, okay? They are poisoned with oxygen. Oxygen is drug. Okay, so that toxicity carries a lot of stuff with it. It can cause a decrease in surfactant production, which would then cause a decrease in lung compliance. It can cause the tissues to die. It can cause the tissues to become more fiber optic. Okay? So the list goes on and on with oxygen toxicity. So like I said the other time, your goal as a respiratory therapist is to quickly wean your patient to below 50% as long as they are maintaining good oxygen saturation. You save them a lot of trouble by winning the FiO2 to below 50%. Okay? Cerebral vasoconstriction, yeah. Too much oxygen will vasoconstrict the blood vessels in your brain. Okay? So we want to avoid that because, if you don't get enough oxygen in your brain tissues are going to die. The brain needs a lot of oxygen. So let me write this down here. So we have, here's oxygen here. Here's CO2. I always remember that. And then here is lungs. So, in the lungs, oxygen is a vasodilator in the lungs. So, if you don't have enough oxygen inside your lungs, your pulmonary vessels will constrict. If you have enough, then your pulmonary vessels will be dilated. Now think about COPD patients. Their CO2 is always very high. They have chronic hypoventilation. And CO2 inside the lungs is vasoconstrictor. So that's how come most COPD patients, when you see them, they're always on a couple of liters of oxygen because we want to keep their pulmonary vessels dilated. Okay? If the constriction inside the lungs goes up, they have what we call the pulmonary hypertension. Pulmonary hypertension. So, in essence, pulmonary hypertension and COPD coexist. If you have end-stage COPD, more than likely you got pulmonary hypertension, meaning that the pressure, the blood pressure on the right side of the heart is gone way above 25/10. The vessels are constricted. But now if we give them like 1 or 2 liters of nasopharyngeal to wear, that will help to vasodilate their pulmonary vessels to some extent. Okay, so that's what we do there. And then in the brain, too much oxygen is a vasoconstrictor. Okay? Too much oxygen is vasoconstrictor. We have to be very careful because when you vasoconstrict, you reduce blood flow. Okay? You reduce blood flow to the brain. The brain tissues are going to die. That's one of the complications of high level of oxygen. And then in the brain, CO2 is a vasodilator. CO2 is a vasodilator in the brain. If somebody's CO2 is very high, they're going to have increased ICP, intracranial pressure. You have more blood flowing into their brain. Okay, the brain is a very rigid structure. It doesn't expand with increasing volume. So it's like you're cramming all this volume in there, which will cause the ICP to go through the roof. Okay? Any questions about that? And then fire hazards. Okay? Anytime oxygen is being used somewhere, you better put up a sign that oxygen is being used. I don't know whether they still do that at the hospitals, but when I was working at the hospital, anytime we start oxygen therapy, we put like a little sign. We say oxygen use, no smoking. Okay. Now think about people. How many people out there do you know that don't even know about oxygen? They don't know what oxygen is. But now they have a family member that is sick and they're in the hospital. Okay. Once they come in there, they're going to light out their cigarette and start smoking inside the room. I've seen that before, So that's why we have to put that sign and let them know that there is no smoking. And oxygen supports combustion. If there's a fire burning, oxygen will make it burn more. Okay, so we want to prevent that. Okay, so equipment here, oxygen blender and flow meter. Flow meters are used to, deliver the oxygen. Okay, a blender is a device that mixes oxygen and air. Like the ventilators have blender in them. So that's how come you have, this is the air hose coming into the ventilator. This is the oxygen hose coming at the back of the ventilator, okay? Once they arrive in there, you set your FiO2, okay? Let's say if I set my FiO2 at 100%, what I'm doing is blocking the needle valve for the air to come in. The air cannot come in to the chamber. So what goes out to the patient is 100% oxygen. If I change it to 40%, then I'm opening up the needle valve to the air to come in and mix up with the 100% oxygen, and then it's blended, and then it goes to the patient. So a blender is a device that mixes oxygen and air. And another name, on the exam, if they really want to be funny about that, they will call it oxygen air proportional. So when they say oxygen air proportional, they're just being funny. Okay, what they mean is blender. Okay, blender. All right, so we have oxygen analyzers. Sometimes when you put your patient on oxygen, you're going to have to analyze to make sure that what you set it on is what the patient is getting. Okay? Sometimes if you don't calibrate your equipment well, okay, it may not be delivering what you want it to deliver. Okay? So we use the analyzer. We'll calibrate the oxygen analyzer to room air. We'll calibrate it to 100% before we use it. Okay? We use humidity. Now, oxygen is anhydrous. It doesn't have any water vapor in it. So it will dry you up like crazy. So we're going to have to humidify the oxygen, especially for the baby. We have to humidify. Babies must always have some kind of humidity when they're getting oxygen. Okay? Otherwise, that will dry them up very quickly. Okay? We have oxygen hood. I don't know if they use that a lot now, but oxygen hood basically covers the baby's head. Okay? And then you can set up aerosol therapy, and then you feed it into the oxygen hood. The rest of the body is out, just the head is covered. They use it a lot when the baby has like a croup, okay, to humidify the baby. Okay. The problem with that is that sometimes if you get a baby that is very active, moving around a lot, okay, they may knock it out when you are not in there, and then they're not getting oxygen and they're not getting humidity either. But if it's a baby that is quiet, settled, and not moving around a lot, certainly we can do oxygen. Okay? Oxygen nasal cannulas and mask, okay, you know what that is. Nasal cannula is low flow oxygen delivery device, very commonly used device. We have tents, okay. Tent is like, tent covers the entire bed, okay, tent covers the entire bed. So it's better than oxygen hood because if the baby wants to play basketball in there, that's fine. They can stand up and jump on the bed, that's fine, they're still inside the tent, you know, getting their oxygen. So if anytime you get a baby that is very active, it's better to use tent than to use oxygen. Incubators, okay, mainly used for transport or to provide a controlled temperature environment for the baby. Okay, now let's say that the baby is born at Presbyterian, but they are very sick, they gotta go to UNM for special procedure. We're gonna transport them with an incubator. It's warm in there, okay, provide a controlled temperature environment for the baby. Okay? And of course, you know what the resuscitation bag is. All right. Well, the one that we take a break to 2:30, and then we finish